Hi everyone, I want to talk about non-Hodgkin lymphoma diagnosis. Before you can enjoy this, please kindly check my video production on non-Hodgkin lymphoma. And if you want to have a complete picture, you can also review Hodgkin lymphoma on my channel. Okay, so 2 videos before this. Then let's go. Diagnosis of non-Hodgkin lymphoma will start with a very good and thorough history. So you can ask about the history of lymphoma in the person that is presenting. Also, personal history of hematological malignancies, radiation, chemotherapy, organ transplantation with immunosuppressants, pesticides, hair dyes, and of course, history of increased vegetables and ultraviolet light exposure would decrease the occurrence of non-Hodgkin lymphoma. HIV, Epstein-Barr virus, Hepatitis C, Borrelia, burgdorferi, Chlamydia, psittaci, and Hepatitis B infections. Can ask about possible history of autoimmune diseases from systemic lupus erythematosus to Sjogren syndrome, rheumatoid arthritis, autoimmune hemolytic anemia, diabetes mellitus, particularly type 1, Hashimotos thyroiditis, scleroderma, and so on. Still on the history, to be nice to know the history of immunosuppressant or immunomodulatory drugs in this individual. For example, history of Cyclosporine usage, Azathioprine, disease-modifying anti-rheumatic drug like Infliximab, Adalimumab, and so on. How about history of means, cryoglobulinemia, Multicentric Castleman disease, inflammatory gastrointestinal diseases, for example, gastritis, celiac disease leading to lymphoid apoplasia. You may not check the individual for possible obesity who might have slight increased risk. You can check for B symptoms here. The B symptoms will include fever, weight loss, night sweats, and severe itchiness. Still on history, and have the history of possible lymphadenopathy if the individual had perceived it or been diagnosed with it in the past, because in case of indolent non-Hodgkin lymphoma, the main presentation will be waxing and waning lymphadenopathy with some organomegaly, like hepatomegaly or splenomegaly. So, other peripheral lymphadenopathy that will be painless, waxing and waning, as in indolent lymphomas or lymphocytosis and lymphadenopathy, are mostly seen after infection. You have to rule out tuberculosis, so history of contact or history of tuberculosis in very patient or the environment the person is living or working. Pertussis, viruses like infectious mononucleosis, cytomegalovirus, or HIV infection. Parasites are not left out, and we need to know what has happened with toxoplasmosis, contact with cat litter, and so on. Also, history of fever of unknown origin, the fever that is prolonged without any cause identified, or extracellular involvement may include bone marrow, gastrointestinal tract. Therefore, you can have aspiration of peritoneal fluid and analyze the same. You can also use computer tomography, positron emission tomography, ultrasound, or magnetic resonance imaging. After the history, then you have physical examination. You have to look at the general appearance of the affected person, whether it's caucasic or giving the clue of weight loss, malaise, weak, any obvious distress or dyspnea, and so on. Then check for rashes and scratch mark, sign of itchiness, because lymphoma could be pleuritic. Chest and lungs for pleural effusion, or the heart for pericardial effusion, muffled heart sounds, distended neck vein, or hypotension, backtriad of cardiac tamponade. Consolidation signs or signs of pleural effusion with stone donors on percussion, and of course you auscultate. Chylothorax, mediastinal lymph nodes, obstruction of the thoracic duct or cisternal chyle in the abdomen or its mesenteric tributaries. You can check the abdomen for hepatosplenomegaly. We'll now concentrate more on extracellular size. We have actually mentioned some of them already, but more on extracellular size, gastrointestinal tract. You're going to examine and take history surrounding that. You're going to check the skin, check the testes, the bone, the kidney, salivary glands, thyroid, prostate, bladder, ovary, orbit, heart, breast, adrenals. In other words, non-Hodgkin lymphoma is widely spread all over the entire body. You can check epidural for spinal cord compression. Central nervous system is either the primary tumor of the central nervous system or the secondary, that is, metastasis to the brain. About renal failure, the blood urea nitrogen and creatinine. Of course, do your analysis. 30 to 60% of non-Hodgkin lymphoma may have an unknown primary site. Isn't that scary? You're going to do all you could to make sure you come down on the sites. Imaging and biopsy in non-Hodgkin lymphoma. Imaging, you can use that for staging, and that will depend on two factors. FDG, that is fluorodeoxyglucose that is the ability or the rate at which the lymph node, the malignant cells will pick up that fluorodeoxyglucose, okay? And of course, positron emission tomography with CT scan. Lymph node and biopsy in non-Hodgkin lymphoma must have lymph node biopsied and examined by the pathologist. As a matter of fact, the pathologists are key to accurate diagnosis of Hodgkin or non-Hodgkin lymphoma. The features will be size greater than 2.2 centimeters squared in diameter. The site of the lymph node, you're going to check if this is an enlarged peripheral lymph node. It might not be peripheral, might be mediastinal, okay, and context. Is this isolated finding or part of a generalized lymphadenopathy. However, fine needle aspiration cytology, that will be the preferred type of biopsy. Genetics, because the predisposing factors might not leave genetics out, so you can have karyotyping and fluorescence in situ hybridization. You may or not have polymerase chain reaction. You can have your bone marrow aspiration for cytology or biopsy. Lumbar puncture, if this is central nervous system involved, and you analyze the cerebrospinal fluid. Endoscopy, if you think gastrointestinal system is involved. So you go to gastrointestinal tract via your endoscope, and you can have pleural fluid, pericardial fluid, or peritoneal fluid, depending on whether you have pleural effusion, pericardial effusion, or ascites. Spleen, you can have splenectomy for the purpose of diagnosis. So you can have what is called diagnostic splenectomy. So you have the surgery, then send to pathologist for diagnosis. Laboratory, particularly if you're suspecting tumor lysis syndrome or otherwise, you can have calcium checked, and you might have increased calcium, but in tumor lysis syndrome, you're going to have hypocalcemia, and you can have increased uremia, that is hyperuricemia, increased lactate dehydrogenase, decreased hematocrit, leading to anemia, decreased white blood cells, easy susceptibility to infection, decreased platelets, leading to bleeding. Serum electrophoresis, increased large monoclonal immunoglobulin, increased small M spikes like B cells, non-Hodgkin lymphomas, chronic lymphocytic leukemia, and small lymphocytic lymphoma. So treatment is going to be very aggressive because non-Hodgkin lymphoma is difficult to treat, and types and subtypes are treated differently. Unlike Hodgkin lymphoma that you could treat and the affected person might be cured 80% of the time, but that is not the case with non-Hodgkin lymphoma. So we choose from CHOP to CHOP to RE, that is cyclophosphamide, hydroxydonorubicin, oncofin, that is vincristine, and prednisone. But you can add rituxan or etoposide depending on the type or subtype, and this could be given in cycles. Actually, the oncologist will do justice here, and you can use CVAD as well. That is cyclophosphamide, vinblastine, adriamycin, daunorubicin, and rituxan. And with that, I've come to the end of this very presentation, that is non-Hodgkin lymphoma diagnosis, and even the diagnosis of Hodgkin lymphoma will go almost the same direction. And the next presentation now will be Lugano classification and revised staging of lymphomas generally. Kindly subscribe to my channel so that once I have this presentation done and they're published, you'll be able to have a copy. I appreciate it. Thanks.